Good evening, everybody. Welcome to our fifth Foundations webinar and our third one in lockdown, and numbers keep going up, so very happy to have you all here today. We've got a packed agenda for you and lots of chance for you to engage in the chat box, which I see lots of you already doing. So welcome to everybody on Zoom, and welcome to everybody over on the DFG Champions Facebook group who are watching over there as well. You're 10 seconds in the past, I think, but we'll try and keep up with your questions as well as we go through the webinar.
The Foundations webinar.
So that's me when I had a lot less hair than I've got now. And if you're not aware of Foundations or are new to us, we're funded by the government, and we're here to help local authorities and home improvement agencies across England. And our focus, has, particularly over the last couple of years, has been on improving outcomes from disabled facilities grants. And we have a whole range of services that you might be interested in, including DFG quality standard assessments. We do free training on DFG legislation and regulations, which we do 2 of those a week. In fact, there's one going on just at the moment. And we do DFG process workshops as well. So if you look at improving how you deliver your DFG system, then either get in touch with me or one of the Foundation's contacts. Some of them are in the chat rooms, and we're happy to come to that for you, virtually, of course.
Find out more at foundations.uk.com.
All the details, of course, on the website. So we started these webinars back in January, before we knew the world was going to change so significantly, and we were kind of aware that time and travel could be difficult, and obviously travel is very difficult now. So we're bringing content straight to you at your desk or wherever you're sitting at the moment. So we're doing the Foundations webinar monthly, and we do other bits and pieces in between. So if you keep an eye on the website again, you'll see all the details of those, where we have content from Foundations and from a range of partners, and get you involved with the chat feature and some polls that we have as well. So today, after we've done introductions, we've got a session on working remotely. We've got Rachel Russell, who's an OT from University of Salford. We'll be talking about some of her experience and research and evidence on remote working or remote assessments. And Philippa from Foundations has got some interesting new developments on how that works as well. And I might chip in 1 or 2 bits as well. We've then got Laura Wood and her colleagues from Invisible Creations, which you may have seen at DFG Roadshows in the past, or at the Healthy Housing Awards last year. And then Simon and Hilary from ThinkCO, or Think Carbon Monoxide, will be giving us an update on some of the dangers around carbon monoxide, particularly if lots of people are staying at home at the moment. And then finally, at the end, we have the DFG Surgery, where I try to answer as many of your DFG related questions as I can. So it's a bit like Martin Lewis does DFG. So if you've got any questions, pop them in the chat box, and we'll try and pick those up at the end.
Poll time. Let's see what you think.
So to start with, we've got a couple of polls to get you into the polling. So first one is, what's your job role? And as a matter of interest, where are you watching us from now? So 2 questions for you today. What's your job and where are you watching from? And if you're on Facebook, if you just put your answers in the message box, I don't think you can access the poll over there. There we go, I'll share the results. So lots of OTs with us today, selection of managers, technical officers and caseworkers, and most people in their home office or on their dining table, and 11 people watching from bed, so at least you'll be comfortable. We'll try and keep you awake as we go through. For the first session today, I'm very pleased to have Francis and Rachel Russell here to talk to us about remote working and is this the new normal?
Thank you very much. Good afternoon, everybody. It's very rare that we get to address such a huge audience. Even the roadshows or the conferences never made this many people. So very pleased to talk to you. I've lost my screen, sorry. I want to talk to you today about the remote working, something we've all got used to in the last 7 weeks. Very early on, this man, he said, we have moved to the principle of digital first in primary care. And without patients, unless there are any clinical or practical reasons, all consultations should be done by telemedicine. That's what Matt Hancock said. Now, this was a huge challenge to the NHS. Seeing as they'd spent years saying why it was difficult to do remote consultations around private and very personal medical conditions with very vulnerable people. Yet the COVID-19 crisis really exposed the need for less personal contact between patients and doctors. And so, could you put the next slide on?
Yeah,
thank you. So on the 13th of March, NHS England and NHS Improvement issued the new total triage guidance, and by the 23rd of March we were all facing lockdown. On the 30th of March, the NHS England issues additional guidance to the CCGs to support GP practices with options for remote working. So the whole thing was mobilised at pace. A month later, on the 28th of April, Professor Martin Marshall of the Royal College of GPs noted that 77% of all GP consultations had been moved online. That is within a month of that statement being made by Matt Hancock, which is an enormous achievement, really, for the NHS. More than 22,000 laptops have been distributed. And what interests me about this is that the phase 2 COVID, the slow unwinding of lockdown, will be with us for some time. So we're going to have to get used to this remote working, and we're going to have to adjust our own practices to reflect that remote working. And you know, the experts are saying that at least 18 months it will be with us. Now, I think that's a golden opportunity to actually put some new ways of working in place that will make us more efficient and more accountable, as well as pointing the right expertise at the right places, because I don't believe that we can move everything online. So and I suppose the point I'd like to make with all of this is that there's been enormous changes driven by that emergency, and we've all noticed it in our own lives, but actually GP consultations noted it, of course. So if you could have the next slide, please. So the guidance that was issued was to support all GP practices with rapid implementation of total triage model using telephone and online consultation, and it created a virtual workspaces and secure interfaces, and all practices had to move to the model as soon as possible. GPs had to avoid face-to-face contact unless absolutely clinically necessary, and that was so the presumption was that the consultation would be remote. And in order to do that, interestingly enough, the NHS turned off all online pre-booking systems and screened all demand directly. So there was a triage. That's in this phrase, the total triage. So all calls came into a professional who then screened that call and placed it with the right person, so to see whether it was appropriate for a remote consultation to happen or not, and how that then could be enabled. It also set out to encourage other online patient-facing services, so access to the records so that the patients knew where they were in the system, the ordering of prescriptions so that actually patients could get their prescriptions delivered without having to leave lockdown, and particularly important for the 1.6 million people shielding, of course. The NHS exploring other enablers for remote working. Sorry, the chat is obscuring my slide. Such as a single sign-on, the sharing of records across the system, something that we've really worked very hard at over the last few years and never cracked, the sort of confidentiality and data protection stuff, and the electronic generation of forms, which we in governing a GFG system would be really interested in, of course, because so much of that, so much of the process is still form-driven. Could you have the next slide, please, Paul? So the guidance came out, and you can go and check. So some of these slides will be available afterwards, after the webinar. And it covered when is it appropriate, who is it appropriate for, how do we do it, and all that guidance can be accessed online. The link is there. It also looked at which apps to use, the issues of confidentiality and access to data issues that people worry about in these circumstances. It had some useful home working tips, because for so many of us, this is the first, I mean, I may be unusual, and I've been working from home for the last 13 years, but for many people, this was the first experience they had of home working. It's a very alienating place to be. It's difficult to keep contact with your colleagues and with the workflow. But crucially is that what they said is that the shift to remote working shouldn't be seen as a tech issue. It is not that we simply give people an app and they will and we can move the service online. It should really be seen as a service improvement project, and therefore engage the whole organisation. It is, in other words, not a tech issue but a cultural shift that people are looking to make in the NHS. Next slide, please. So Rachel has done some work for us to look at the pre-COVID evidence base of remote working, and I'm hoping that she can butt in at this point.
Yes, I'm here. Don't worry, I'm here. Is my video on?
Don't know.
It is, yes.
All right, okay. I might just turn it off because my bandwidth is terrible. Plus, I've got COVID hair, as I think we're all supporting COVID hair. So I'll just turn my camera off, and then you don't have to put up with my COVID hair. Right. So what I've done is I've just done a very quick kind of down and dirty review of the evidence base around the use of remote working in terms of housing adaptations. So like I said, there's no huge amount being published specifically about housing adaptations, the role of home improvement agencies or similar, and occupational therapists working in housing adaptations. There is a lot of evidence from other areas of occupational therapy in terms of telehealth and telerehabilitation. And I have been able to find about I think there were about 3 or 4 articles that kind of focus on telehealth and adaptations. So as I talk about this, what I need to say, these are really small scale studies. So in terms of the gold standards, in terms of research design, they're really small scale studies, and there is some questions around the methodologies, but I still think, despite those issues, that these articles, the evidence is still useful, and I think provides us with some useful insights as we think about actually how do we use this, as Francis says, how do we use this as an opportunity to improve what we're doing as practitioners in housing adaptations. I don't think you'll be surprised, but the articles or the research or the evidence base that is out there was either from the USA and Australia, and I think we can all begin to understand why that might be. Obviously, in terms of Australia, the geography as the same in the US, but also the health model in the US is different, and I think that's influenced their move towards telehealth and telerehabilitation when you compare it to us here in the UK. So just to give you some broad headlines, in terms of how telehealth, telerehabilitation, remote working is being used, tends to be around the assessment process. So that's initially, going to see the person, or, meeting with the person online or via telephone or by whatever remote technologies that we're using to actually identify what the issues are. So what is it about that person's home environment that is stopping them doing the things that they want, need and have to do in their everyday life? So obviously there's it's being used around assessment and identifying what those problems are. The other area it's being used is in terms of you know, trying to find, okay, what's going to be the best solution in terms of resolving this person's difficulty. So what is going to be the best design or type of adaptations to install to help that person do the everyday things that they want, need and have to do. So as I say, in terms of how these technologies are being used, it's being used for assessment as well as designing the adaptation, and also to a certain degree kind of managing the adaptation process as well. It's being used in a few ways. It can be either used synchronously or asynchronously, or a combination. So synchronously is where you're actually meeting the person live and you're doing the assessment, or you're looking at, you know, the solutions with the person there and then. Asynchronous is where you are sending the person information out that they then fill out and then send back to you. You then analyse the information that they send back to you and you come up with your recommendations. Or there's a little bit, so there was one study that kind of combined the two, and that this seems to work really well, where you're preparing, you're sending the person, the service user, information about the things that you know, the type of information that you are wanting to know before you then meet them online, and that seems to work well. Preparing the person ready for them online. Different technology use, so things like photographs, so use in assessments and provision of solutions. So this is where the person sends you photographs to have a look at, and you're doing your environmental assessment from the photographs. Obviously, teleconferencing, telehealth platforms. I am aware that there's a number of teams out there in the UK. I think there's a couple of teams out, up in Scotland that are using telehealth platforms to carry out their environmental visits. I know a lot of OTs at the moment are doing home phone calls and using WhatsApp and all other bits of technologies to support that kind of triage in that initial assessment. So in terms of what the evidence says, I think in terms of it improving what we're doing, I think, you know, as I said, these are only a small number of studies, but I think it does show promising. I think obviously that it has some advantages around reducing travel times and providing some flexibility. But I also think there's some advantages around expertise. So if you've got you know, a practitioner who's got a really set of skilled knowledge around a particular condition or a particular way of designing things, or by using telehealth or teleconferencing, you can kind of access that expertise even if that person isn't in your locality. It seems to be effective. So where they've compared face-to-face home visits with telehealth home visits, the outcomes seem to be very similar. What should be positive, what should be reassuring is that the telehealth assessments, the therapists tended to over-prescribe. So they would recommend, say, grab rails where perhaps they weren't needed. But you're better to over-prescribe and recommend rather than under-prescribe, where you might end up leaving the person with the risk. So I think there's some reassurance. I think the other thing as well is that we have to appreciate that if we had two OTs doing an assessment, the chances are there's going to be, because we're all individual therapists, we've all got different levels of experience, etc., that we don't always agree. So you naturally get some differences in assessment outcomes anyway, even if it's face-to-face or online. What's really important is it's not just about going off using technology. It's about having the processes, the procedures, the protocols, the assessment tools in place to actually support the process and to support the use of the technology that's out there. I think one of the things that's really important is, although asynchronous assessments have been shown to be useful, I think what is clear is the importance of actually observing the person in that environment, so you can see that interaction. And that seems to be really important, not necessarily in the assessment, but sometimes actually understanding what's going to be the best solution for that person. So actually, that being able to observe the person interacting with their environment is really important. The other thing that I've just quickly missed out is it's also the technology has to be acceptable, not only for us as practitioners, but also for the service user and the carer, and that this technology, you potentially going to face barriers if people aren't comfortable. So I think there's a whole lot of questions that are raised around telehealth, telerehabilitation, remote working, in terms of, you know, managing people's expectations, training people around the use of the technology. Somebody mentioned in the chat box around if the RCOT has published any specific guidelines. One of the things I would say for any occupational therapists out there is, whatever you do, even if you start remote working, looking at different ways of working, you've got some really valuable resources that you can access, which is basically your RCOT, Code of Ethics and Standards of Practice, and your HCPC. Use those documents to kind of think, right, am I getting informed consent? Am I practicing in a safe and ethical way? So use those documents if you are kind of moving towards a different way of working, to kind of look at your practice. Sorry, I've wibbled on, haven't I? Sorry, Francis.
It's brilliant, Rachel. So bearing in mind there are 150 odd OTs on the other side of us, I think it's gold dust, really.
Yeah. Okay.
And it brings it down to the working level, which is where I'd like to go next.
Yeah. All right. I'll shut up.
Okay, so do you want to just carry on through these couple of examples, Francis?
I'd love to, actually. So I've talked about the NHS and in particular the primary care services because they shifted en masse to online consultations and remote working. We all did, of course, but much of the DFG market is quieter or laid very quiet, waiting for new ways of working to emerge. And one of the things I thought about as I was looking around, there were some pre-COVID examples of remote working, and one of which is a firm called Resi. And they set out to be a market disruptor and act within the architectural design industry, and have actually become the UK's leading architectural practice for everyday homeowners. That's what they call themselves. They do about 120 projects every month, all of which are mediated on a remote and digital platform. They'll have a good website. You can have a root around on it. What it basically is that platform means that it's not reliant on everyone visiting and assessing and consulting with the clients personally. There is a single point of personal contact, the designer, and the customer has access to an accessible customer dashboard, so that he or she can see where their scheme is at, and most of the stuff that Resi does at the moment are things like loft conversions, extensions, reordering internal spaces, including bathrooms. So major market leader. What's interested me about this was that they existed pre-COVID and emerged out of the frustration with an industry which was largely personal and fee driven, and actually that largely personal and fee driven really put me in mind of the DFG process. They still face challenges, of course, and it's interesting to look at the challenges they face. The first challenge they face is accurate first surveys. So that initial survey still has to be done in person and be measured accurately and transferred to a drawing of some sort or another. The second challenge they face is one of quality assurance, and they've looked to Trustmark to ensure that the contractors that they employ or that they get to tender are actually of a certain quality and can be quality assured, even remotely. Now, we all know that that's not as simple as it sounds, but it's interesting to put those challenges out there, because those are the challenges we will face too. Next slide, please, Paul.
Worth saying, if you're looking to get any extensions done at the moment, you might want to think about Resi doing them for you.
Yeah, it's true. Yes, no. I think in terms of Resi's ability to do this, it's actually. I think that local authorities, it could be a really good adjunct, because you can spot purchase their services, of course, and because their fees are visible up front, you know exactly how much to put in for any large scale schemes. That shouldn't change over the lifetime of that project. So the next thing I wanted to do is to reflect the experience of a home improvement agency, and I spoke to Becky at Oxford City, which has really taken a very can-do attitude to shifting all this stuff to home. They already had the advantage of having a highly visible service offer, and that meant that the HIA number was linked to a group of Sorry, I'll start again. They have a highly visible service offer pre-COVID, and it meant that it was well known across Oxford about who to contact if you had any housing difficulty. That number, their central number, has now been linked to a cascade of mobiles of the HIA practitioners, all of whom are at home. Now, DFGs and minor adults still go through the call centre, but they too have managed to put some sort of remote process in place, and the referral sent through to the HIA as normal. So once that referral is made, an OT carries out a phone assessments using mobiles and tablets, and it's interesting that I've seen some of this going on the Facebook group as well. So there was a question earlier on in the chat box about WhatsApp. Certainly WhatsApp is used quite a lot. It is encrypted, of course, and has that advantage. It tends to be helped by family and carers as they go through. Oxford is then helped to push that work through the MIS workflow system for allocation around the HIA team. That is from the OT recommendations to the technical officer. Most works are called off from a local framework, so that's in place. Schedules are based on the knowns, and what that means is that actually there's so much information. When I spoke to Becky, she says it was really remarkable how both OTs and technical officers could make out quite a lot from photographs, and actually with a decent framework, a schedule of rates, you could pretty much get to a reasonably accurate estimate of what the job would cost. And then what Becky then said is that for the time being, they've accepted variances as a matter of course. The contractors, in terms of working in people's homes, are bound by the government's guidance on working in people's home, and that's expanding all the time. It's becoming quite smart. Applications, the DFG applications, the casework stuff is all completed by phone. So the works are signed off by calls to the client. Are they satisfied? Are they happy? And they're backed up by photographs from the contractor. So for her, the challenges remained the technical service. It's interesting that remains that is the challenge for Resi. It's also the challenge currently in the sector. So I think that technical survey will have to be done in person, and we'll have to find ways of working that through social distancing to do that safely. The second challenge she noted was document transfers and consents. And this is quite interesting, because actually what she has to do is, although we can email or send paper contracts and documents and agreements and specifications to the client for signature and all that sort of stuff, you're reliant on snail mail, on the old post, and there has to be a better way of actually getting consents from the client. And the challenge will be whether we can devise systems that allows people to consent through a similar system that Resi uses, actually, some sort of dashboard that the client can consent on, either through a personal password or some other encrypted signature. So it's so fast moving, the whole thing, that's very much what I found. Now I know that Paul's had Paul has had some ideas about managing builders remotely as well. So maybe you could take that away, Paul.
Yes, I had my boiler broke a few weeks ago, so I went through a service called Boxed, which has a very nice online system for getting a quote and booking a boiler replacement. But then they also had a very nice approach for how they audit jobs once they've done. So as I do, I've tried to find an app that would replicate that for everyone else to use. As everyone else at Foundations will know, we have quite a lot of apps. So this is the on-site checklist that I found. And thank you to Kevin from Norwich for sending me his checklist, which I've put into this little app. And this is how it works. So you can have a number of templates on the system. So we go into the shower adaptation template. You start by adding your reference details. So you put the job reference in, date for inspection, you put an address in. And once you put the address in, it will link to that place on the map in a second. And put the client's name in. You can add a photo of the house or the bungalow or whatever it is. And see, if you click the bottom, you can add the locations. You can zoom in on the map to where you put the address. You can do it twice. So once you put in the details, you go back to your list of items. And it's broken down into sections. So for the shower, for example, first check was the shower runs. So you tick yes, it does. You can add any comments. So for instance, 3 litres per minute. And you can add a photo of the shower running. You can either add the photo at the time, or if you've already taken the photo, add a copy of that. And you can work through your checklist for all the other items about the shower. Go to the wash basin, for example. If you want to the joint between the wash hand basin and the pedestal, yes, that's fine. Again, add a photo. And one last one, the toilet isolation valve on the feed. So there's one there. Again, attach the photo. And if there's anything wrong, you can add a note of what needs completing. Add your date, and that adds it to the report. When it's all done, you can add any final comments. If you want to, you can also collect a signature. So it could either be the person doing the survey, or you'd use the client signature if you wanted to collect that. So my thinking was that the builder, on the completion of their job, as Box did when they came fitting my boiler, could do all this, send it to you in, and you could sign off the job without having to visit it at the end of the process, which saves you one visit. Because what it does, once you go back to the start, you click on it, and you can export it as a PDF report, which has all your photos and your notes contained within it that you can share as you want. So that the builder could do this and email it to you as evidence that the job's been completed satisfactorily. I think the other thing you could do, perhaps not all your technical officers or surveyors perhaps are going out doing visits, they may be uncomfortable with that, and perhaps 1 or 2 could be out doing surveys, recording the various bits and pieces around the bathroom, and actually share that with whoever's going to draw it up, and actually with the builder. So it might be a good thing to actually use for jobs generally going forward. So I think it's quite a nice little tool to use. So that was as simple as it is, and you can set up all your templates to use as you like. Details there's the list there. So Kevin from Norwich sent me a template which I inserted into it in about 2 minutes. So how much do you think that would cost, and how useful would it be to you? I will start another poll and see what you think.
Poll time. Let's see what you think.
There we go. So what's that, about 70% if you think that'd be useful, and worth £50 is the most popular answer. And actually it costs one-off cost of, it's just £5 you can get from either the Google Play Store or the Apple Store. So it's £5, download it onto your phone. You can, on their website, you can set up your own templates, and away you go. £5 one-off. So your builders could have it, your surveyors could have it. Really cheap and easy to do. That could save a few visits, and I would just mention DFG tenders as well, which I know I've talked about at previous webinars. It's our online dynamic procurement system where you have all your local builders' prices stored in the system. You set up what you want for each particular job. It pulls through all the prices, saves them having to go and visit and do quotes. So if you're interested in that, you can use it free for the first use of 6 months, and there's various options, and now you can pay for it after that. So if you're interested, drop me a line. I can do your demo of that separately. Yeah, so Simon's question is, yeah, that's £5 per user. So each contractor, it's £5 a go. So everybody who has it on the phone is £5. So has anybody got any questions for either Francis or Rachel on remote working?
So there was an interesting question from Amy, Paul.
Yep.
Amy's asked, because you've just unpacked a buildery version of what is effectively an assessment, asked whether there's anything equivalent for OTs, and it struck me that the comments that people in Oxford made was that how much information you could get from a phone assessment, certainly a mobile phone assessment with WhatsApp or other personal videos. But I do wonder whether you've heard of anything, Rachel, that enables OTs to do a little bit more structured assessment.
I know this now. He's not an OT, but Salford. For the stuff that he's developed around telehealth to structure the home visits and the environmental visits, he has got a tool, and I can if anybody wants the details, if they email me, I'll put my email address in the chat box thing. If anybody wants,
it is interesting because again, pre-COVID, there were some examples out there. Natalie's just landed on Ask Sarah, but there was also ADL Smart Care, which actually had ways of assessment, either guided or self.
Yeah, there's an Australian, because I think we use it as an example in the DFG review, Paul. There's an Australian occupational therapist who's developed like a walkthrough kind of immersive thing. So you access it on your computer, and then you kind of walk through. And yeah, also you've got things like the Dementia Design Institute at Stirling. They had their virtual home environment as well, which, like I say, it's not necessarily an assessment tool, but gives you some ideas around if somebody's got a problem in a particular area of the home, it gives suggestions and solutions. So it could be a tool that that you give to a service user to kind of get them to start thinking about, you know, what the issues are and what some of the solutions might be. I'll see if I can find the Australian tool.
What struck me about the conversation I had with Becky was that she said, and they employ an OT, and she said the OT could glean so much from that phone assessment. And because actually the DFG program consists of 90% level access showers, stair lifts and ramps, there's quite a lot of the program that can shift to remote working. I think that the complex stuff would still need to have some sort of
I just think
that's the thing, isn't it? It's about
I think the other thing as well is that now those of you who know me will know that I was a practitioner on the ground for 18 years before I went into the wonderful ivory tower of academia. So I have worked on the ground, so I do know what it's like. But if you think about the number of time, how long people might be on a waiting list, and actually you could send them, you know, some kind of protocol, some kind of sheet that they can actually begin to start filling out, so that they can begin to start thinking about what some of the issues are, so that you've got that information. I mean, I know most of us, most teams have got triage tools and referral forms, but this would be something that would actually gather a little bit more information, so at least you've got a bit more depth of information before you actually did the visit, and that would actually save some time. I think it helps to frame the purpose of the visit and why you're doing the visit, and the purpose of the of you doing the assessment. So I think that would be really valuable. Obviously, you're relying on the person being able to engage in that process, so it's not going to be accessible or inclusive for everybody, but it could be something that, you know, might enhance and improve the quality of information that we're already getting. Plus, it means that people start to feel part of the process from the beginning, rather than you coming in and draining them of all that information, that they feel that they've, you know, they're part of that process. Am I making any sense?
Yes.
Yeah. There's quite a lot of challenging to the principle of remote assessments coming in, and it's interesting that I did sort of half expect that to happen. I think there was I think the NHS experienced exactly the same until COVID forced them online, and actually that's the challenge that we now face, isn't it? It's just I think that the profession will have to have a closer look at this, because actually if primary care services can do it, OTs should be able to do it. Now, I'm not the person to then say, and this is how you should do it, because actually I think that's for the profession to sort out. But I think it must be possible. And
I think it's like anything. At the end of the day, it's about, the technology is not going to be right for everybody. So you as a clinician, you may not feel that it's right for you. But if you're an independent occupational therapist who uses home adaptations, you know, actually remote working using telehealth might be a really effective way for you to be able to have a number of clients. For some clients, they perhaps would rather do the visit over telehealth rather than having somebody to come. So I think there's always different perspectives, and it's not about saying that this is going to be the only solution. I think it's coming with the mindset, this is the technologies. How can we actually use it to improve what we're doing? Not dumb down what we're doing, but how can we use it in a positive, proactive way to actually enhance what we're doing? So I think there are lots of issues around training that we, you know, and it's about having these conversations, by being challenged, it allows us to think about. At the end of the day, I prefer to shop through Amazon because that's just what I prefer to do. So it's about you seeing this technology as an opportunity to look at different ways of working and to broaden the range of ways in which we deliver the services.
So
I think that's a nice way to sum it up. I think we'll have to move on to the next topic, but thank you for that. I think that's a really nice.
That's all right.
Sum it up, and I think there's lots of questions in the chat box that have come in over the last minutes. So if we ask you to have a look at those, we'll move on to the next item. Thank you.
Time. Let's see what you think.
So, given all of that, and I know some of you have answered in the chat box already, so how are you handling remote working at the moment? So majority doing video and phone calls only. Some are visiting urgent cases, 4 people visiting all cases, but 15% not doing any new cases at all at the moment. So thank you for that. We'll share the video and share the polls after we've finished. So we're not doing a webinar next week, but if you're looking for some online content, next Wednesday is the ISO Aging Society's online forum agenda. If you go to www.agileaging.org, you can find the full agenda there. I'll be speaking in a session in the afternoon about retrofitting adaptations and standards should be involved for that. So yeah, it's on all day, but there's certainly a section on adaptations in the afternoon.
And now it's time for the guest.
So move on to our second guest of the afternoon. I'm really pleased to have most of the team from Invisible Creations here today, and I'll hand over to Laura, who's going to go through the presentation for you and tell you a bit more about Invisible Creations. Start up. There you go. I will hand over control to you, Laura.
Hi everyone, so I'm Laura Wood from Invisible Creations. This is my very first online virtual delivering of a presentation, so please be gentle with me. I've also got Karen from ProCare and Chelsea from Invisible Creations here with me to assist with any questions. So they're going to try and answer all the questions in the chat box. If for any reason we can't get to all the questions and you're happy to share your kind of work email address, we can obviously send those over. And we'll also have mine and Chelsea's email address on the last slide. So if there's anything that, again, we can't cover or can't answer, please just feel free to drop us an email. So Invisible Creations, we specialise in providing accessible, attractive and inclusive adaptations. And we're proud to deliver our products in partnership with ProCare, who you might have heard of already. I just want to take you through kind of the story of how we came about, because it was quite unique. From being part of an innovation programme delivered by the National Housing Federation, to meeting the Prime Minister, to being invited to Number 10 to talk about the work that we've been doing. And we've been on quite a journey over the last couple of years. So it's worth just probably showing a video that captures that journey and tells you a little bit more about who Invisible Creations are and how we came about. So I'm hoping the technology is going to work and you are going to be able to hear and see this video properly. It might be a little bit of a delay, so the words might not marry up. I am one of the co-founders of Invisible Creations, a social enterprise supporting people to live independently for longer. Last year, I was on a programme that was run by the National Housing Federation to look at some of the biggest social challenges we face today. We were tasked with looking at the issues surrounding the ageing population. So we did a lot of work with the Centre for Aging Better, and they provide a whole wealth of research around some of the kind of biggest issues that people were facing.
So we commissioned research and found that actually really minor, low-cost adaptations to the home have a huge impact. They're cost-effective for sort of health and social care savings, but also for the individual themselves and how they experience the home environment. Things like grab rails.
Grab rails are actually one of the most effective products you can put into someone's home. And the thing that we couldn't get our heads around was, well, why aren't more housing associations installing these earlier? So something actually that is so vital to keeping people independent, preventing falls, keeping people mobile. People would rather risk a fall than get them installed.
The products that are available, there's a lack of options. They very much look like the type of products you could imagine in a hospital. They're a reminder of things that they no longer can do in homes that they have often lived in for their whole lives.
My grandma Sheila, she needed the adaptations to help support her so she could get around the bathroom, but she refused to have them because it made her home feel like it was a hospital, and she spent enough time in them, she doesn't want her house to be like that as well. So that kind of struck a chord. We've got these adaptations, these kind of ugly plastic grab rails. Is the solution not really simple? Do we not just design something better, something attractive, something that I would be equally proud to have in my home as Sheila does in her home? We went to the National Housing Federation's conference in September, so that was kind of the big moment to reveal this is what we think is the solution. So we did a pitch to over 800 kind of sector leaders. The reaction that we got at the pitch was completely overwhelming and nothing that any of us could have expected. Some people were asking to buy them there and then, and we literally had 4 prototypes. To get that kind of initial feedback on the work that we'd been in a bubble doing for 16 weeks was huge for us.
I think the products that they've come up with are absolutely fantastic. Any innovation in this space that challenges the environment and says these are different types of choices, what we could do differently, gets that whole area moving in a way that it hasn't done before.
Ageing wasn't something I ever thought that I would get passionate about or interested in, but once I'd realised that this is such a huge problem, I just knew that it was something that we needed to focus all of our energies in and try and drum up as much support as possible to make a difference. So for me, Invisible Creations isn't just about products, it's about people. It's about giving people, as they age, better options. It's about making people feel happier about aging. As a society, we've all got a responsibility to look after our aging population, and I think we've maybe lost sight of that. That was painful watching myself in different freeze frames there, but I hope it wasn't as painful for everyone else. So as you can see, we have had quite a unique journey. We started off on again, we don't need to see that again. We started off on an innovation program with a simple idea, and we're really lucky that 2 years on from that program, we were supported by several housing associations across the social housing sector to actually make that idea into a reality, into a real business. We're now really proud that we've launched with the support of Carbon Homes, Anger Hanover and Johnny Johnson Housing, who between the 3 of them now own what is Invisible Creations. So probably thinking by now, what are the products? Normally this is the point in my presentation where I would have the physical products with me, but obviously because I'm at home, I think I do only have 1 product, but I have got some images on the slide that you can see here. So our whole ethos at Invisible Creations is to design for dignity. And that means for us that we design products that remove that negative stigma that's currently associated with a lot of grab rail and adaptation products. We believe that homes should be a haven, not a hospital, and that these products should be attractive and not clinical. And that's kind of been the main starting point from how we approached our design. So we used inclusive design, techniques in order to come up with the products that we've got. We started off with 4 simple designs, and they're the ones that we've developed now through to the products that you'll see on the images. So we started with the external rail, and we started with that one initially because that was where all of the research and all of the feedback that we were getting, saying that actually that's one of the ones that people refuse and one of the ones that people hate the most out of a lot of the products. And that's simply because that's the one that's on the external area of your property, and that's the one that everyone sees initially. And a lot of people were saying that that acts as kind of like a beacon or a label, that there's someone vulnerable living within that property. We also discovered that there was a lot of doorstep crime related to having some of these items on the outside of homes. So we realised that it was also a safety issue as well. So we thought, well, isn't the solution really simple here? Don't we just create a product that has the functional aspects of the grab rail itself, but is actually a really attractive product that you wouldn't necessarily at first glance realise was a grab rail? So we went with a flower pot. Simply because it's an attractive product, it's something people are used to seeing on the exterior of people's homes, and it was a nice, easy way to disguise the grab rail. And then we've had really great feedback on this product in particular, because, as I say, it is the one that is on the outside of everyone's homes that they see first. We then moved on to the inside of the property, so looking at the bathroom. We started with the bathroom because that's the place that we were told has the most slips and trips, can be the most dangerous place in the home. And we went with 3 products initially as kind of like an early intervention tool. So we have the toilet roll holder. Again, just kind of that early being able to support you getting on and off the toilet when you're starting to lose your mobility slightly. We've also got a mirror, and we were given this feedback by some OTs and some technical officers saying that a lot of time people will hold on to the sink or the basin, and we've had stories kind of from housing associations, from repairs teams, saying that actually that's come away from the wall. Because obviously it's not designed for you to hang on to every time you are brushing teeth, applying makeup, shaving. So we came up with the mirror design, which has got a handy shelf and grab feature on there as well. We've also started looking at kind of the next design phase as well with that product, because we had feedback from some OTs saying that actually sometimes the sink might be over a window, so the mirror itself might not work there, or the mirror might be too big. So we've actually designed just a shelf feature that could be placed somewhere else in the bathroom strategically to help that person get from A to B. And then the third product that we've got in the bathroom is the shower shelf. It's a corner shower shelf. And this was one that we put together because we were getting a lot of feedback around the fact that sometimes there's a compromise of space in the bathroom. So you might have a shelf in a place where you need to put a grab rail, and you have to make that decision between, well, the grab rail is going to kind of win over the shelf. You remove the shelf. And then we've had stories of people then putting their products on the floor, having to then bend down to get the products, which makes it even more dangerous in terms of them slipping over. So we kind of combined the two. Again, all of our products have that kind of dual purpose element to them. So you've got a place to hold on to the rail itself, and you can put your products on there as well. So we have got these 4 products initially in the range. But we are developing the next stage. We're aware that this is only one small part of the solution, and that all of the bathroom needs to be done in the same way to get rid of that kind of clinical feel that we currently have. So our long-term goal is to have a full bathroom pack, so that when you're specifying for the DFG and for other bathroom specifications, you can actually start to include this as a full pack. So that's the products. Obviously, I can't show you them in the flesh, but we have got extra images and dimensions that we can send you if you would like them sent in more detail. And you can also see them on our website as well. So just to give you a bit more information about kind of what we've been doing with local authorities and with housing associations, we've been working with quite a few, up to about 40 or 50 housing associations and local authorities across the UK so far, to try and move to a more kind of preventative approach. So looking at installing these adaptations earlier, because we know that one of the biggest barriers, not the only barrier, there's obviously quite a complex system around this as well, is that kind of clinical medical look that comes with them. A lot of people will delay them as late as possible until they get to the point where they really do have a need and get them put in. So we're saying actually they'd be so much more beneficial if people accepted them earlier and they started kind of being that early intervention tool. So the inclusive design and the prevention element for us should be at the forefront of all our future processes. So we have got housing associations signed up across the UK, not only just to put them in their new build properties, but also to start putting them into a lot of their mainstream stock as well. And because we know that the figures show that a lot of older people are living in mainstream general needs properties that aren't suitable for their needs. So they're starting to look at things like bathroom refurb programs, independent living schemes, cyclical works, maintenance, voids, to start putting some of these products in as standard items in the home. So the message that we have kind of gone around and promoted quite cheekily really is telling everyone to ditch the depressing plastic ugly grab rails. That's kind of our main mission and aim in life, to get to that point eventually, because you know, when we all get to the position where we might need these products, we're not going to want them in our homes. So why are we saying that that's the only option that they've got currently? So we're wanting to move away from all of that really clinical looking product to something that is a lot more attractive, inclusive, and can be disguised quite easily. So for us, we are putting out the message that we need to move to a model that puts prevention, attractive design and strategic installation at the forefront of all future processes. We know that clients, customers, tenants don't want the clinical products, the products that remind them of hospitals, remind them of the mobility that they've lost. And with Invisible Creations, we think that we have the opportunity to give them something better, something that they actually want, and to install them earlier so that they can start to make a real difference sooner. We're already working with a lot of organisations, as I said, and we think that these products could fit very nicely into the current DFG packages. And as an example, we're working with Believe Housing, who are based up in the northeast. And they have their own in-house occupational therapist, and she's been an amazing advocate for what we're doing, and she started to specify these into all of their new build properties for older persons, which is great for us because they're getting them in as that early intervention, and we're also doing a bit of a proof of concept piece around that to kind of test that user feedback, so we'll be publishing stuff on that next year. And then next slide is, this is Sheila. So for us, Invisible Creations isn't just about products, it's about people. And so I wanted to share this case study with you just before I finish today. And that's because for us, Sheila represents millions of people dealing with the same issues. So people being made disabled by their homes, people who live in homes, even bungalows who are supposed to be designed for older people, that have steps that make it difficult to get in and out of those homes. People who need grab rails to help keep them mobile and keep them independent, but often wait too late to get these installed. Sheila herself, she refused to get the grab rails installed. She was very adamant that she didn't want them because for her they represented that kind of loss of independence. They were a reminder that she couldn't do things that she once was able to, and they just made her feel kind of old and vulnerable. And for her, she's a super trendy woman who wants to kind of stay feeling young. She's really young at heart, so for her it was a real kind of like loss of independence for her, admitting defeat with getting these products. She unfortunately had to get the grab rails installed, as you can see on the photo where she's got her thumbs down. She wasn't very happy about it, but it was one of the conditions of her coming home from hospital, is that the specification was that she needed to get these products to help her move around her home. In her words, if there had been a more attractive option, a more discreet option, then she would have definitely got them installed before now. So Sheila didn't get the adaptations installed early enough, and as a result, her health really suffered. And we want to make sure that no one else has to go through what Sheila has been through, that people have a better option, that they have adaptations installed sooner, and that they remain happy, proud, and healthy for longer. She's super happy, as you can see on the other image on there, with the new product that she's got. It gives her dignity back, and she's really proud to have this product on her home. She sent the pictures to all of her friends because she was really proud that she's got a better option. Sorry, I keep losing my mouse every time I go to... So Sheila isn't an average case study. She isn't just a persona that we made up. She's actually my gran. And she's actually the reason that we came up with Invisible Creations in the first place. Not just because I was sick of her moaning about her grab rails, but actually because I really wanted to help her and a lot of other people get these installed earlier. We've also got just a little video to show you. This was filmed during lockdown because I'm classed as one of the carers, so I'll go around and help. And she's actually super, super happy. And I think it just kind of sums up. So Sheila doesn't want to be defined by her age. You know, she's really young at heart, and there's so many other people out there that do want better options and don't want something that makes them feel old and vulnerable. So just to kind of finish off, again, our products are actually available to order now. Obviously, there has been disruption, and there will be further disruption in terms of accessing homes and starting to get some of these products in. But they will be available for delivery from August onwards, all being well. My email address and Chelsea's is also on this slide as well, if anyone does want to get in touch. And I haven't had a chance to look at any of the questions, so I'm just really hoping that Karen and Chelsea have been on those. But if there's anything that Karen or Chelsea want to chip in. Are we all good?
I know they've certainly been typing away while you've been talking. I don't know if they've got any anything they'd want to answer live.
Just briefly, we're really sorry we haven't been able to answer all your questions, but I've done a mass job of copying over as many answers as possible. So I'll send those, as many questions as possible. So I'll send those over to Paul with our answers, and he can circulate them after. I'm so sorry we couldn't answer everything live.
Great. And I think kind of the main one, people were asking about price. So I think you said on one of the messages, if people email you, you can send them a price list.
Yeah.
Yeah. I think quite a lot of the chapter has been about price. I think the issue is whether you stick with something that kind of the white plastic ones that are almost disposable, which they might cost 98 pence to fit once, but they're ripped out and then fitted again, perhaps for the next tenant. But if you fit something that's, I suppose, more like this, then actually in the long term, it's fitted there, it stays there for many years, and you don't have the costs of fitting and removing, which cost more than the grab rail in any case.
Yeah, so we've gone with that with stainless steel, with a brushed steel finish, which lasts a lot longer than some of the current products. So we had kind of reports of people saying once the plastic coating kind of comes off a bit, you get rust, obviously ruins then the tiles or the walls. That won't happen with these products. So it is something that you could put in, and it does last a lot longer. And one of the things that we're working on with housing associations and local authorities is that it's that kind of invest to save model. So they might be a little bit more expensive at the front end, but actually it's something that you can leave in that property for a lifetime, really. So
yes, absolutely. So thank you, Laura. I think there's still a few questions coming through in the chat box, so I will leave you to have a look at those, but thank you again for contributing today. Thank you. And the entries for this year's awards are open at the moment. So there's a range of categories. So if you're interested in entering that, and we'll have a ceremony when it's safe to do so, it's healthyhousingawards.co.uk.
And now it's time for the guest.
So our last or penultimate session of the day, I will hand over to Hilary Bath from ThinkCO and the Gas Safe charity to talk to us about carbon monoxide poisoning. So I'll give you control of the presentation, Hilary, and away you go. Great.
Thanks ever so much, Paul. Can everyone see and hear me? Let me see.
I think so.
Okay. Hello, that's a heck of an introduction. Thanks ever so much for that. My name is Hilary Bath, and along with my colleague Simon, who will introduce himself when he does his bit to you a bit later, we're here to talk to you this afternoon about a programme called ThinkCO. Now, some of you may have heard about this already, but just in case you haven't, what it is about is raising awareness of the dangers of carbon monoxide poisoning in the homes of vulnerable people. And it's funded by the Gas Safe charity. Now, again, many of you may have actually heard of the Gas Safe charity, mainly because it is one of the funders of the FILT programme. So it sits behind that as well. But one of the other work streams is the ThinkCO programme that we're going to introduce you to now. So in terms of our slot this afternoon, the structure of the session is going to be a bit about the programme very briefly. And then we've been asked to actually probably update most of you, because I guess many of you will actually know about this already, some of the dangers of carbon monoxide poisoning, in particular what to look out for in terms of the sources, signs and symptoms of CO poisoning. And then I'll hand over to Simon to actually talk a bit about how to help prevent CO poisoning in the homes of the clients that you work with, and also what action you can actually undertake if you suspect that there may be CO poisoning present in the home of someone that you're actually working with and supporting. So what we're really doing is a précis of our main ThinkCO messages with you this afternoon. And also it's the précis really of an awful lot of what is actually outlined in the programme, which I'm about to introduce to you. So the ThinkCO programme is mainly face-to-face workshops. So what we've got on the whole, when the world is normal, unlike it is at the moment, we run face-to-face workshops with people who work in the homes of vulnerable people. What makes this awareness campaign about carbon monoxide different from others is that our target audience are you. They're the people who actually work in the homes of vulnerable people. It's not targeted at the general public. So we're keen to work with you if we possibly can. For obvious reasons, the face-to-face workshops are on hold. They've been on hold since mid-March. And obviously they're unlikely to come back until potentially the autumn, but even potentially next year. So in the meantime, what we've been working on is an e-learning course. Now, again, some people may have actually done the course. Certainly, we've had quite a flurry of OTs doing the course. So some of you may have actually been on and done it. But all you need to do, and Simon will sort of say this again at the end, all you need to do if you're interested in an e-learning course, which mirrors the sort of key messages that we're going to be sharing with you this afternoon, is simply to email us at e-learning@gassafety.org.uk. We can actually put that on the messages. But also, as I said, Simon will say that email address to you nearer the end as well. What we also have, as well as the e-learning course, is some online workshops that we're planning to do. We're hoping to do them in June. We're testing them at the moment. It may tip over into July. But actually, those online workshops will be a bit like this. It'll be a webinar where you'll be able to sort of get the sense of what it's more like to actually work and be interactive, rather than have someone like Simon and I talk with you for 20 minutes. But we also have a signed subtitled video. In particular, we were asked at a workshop once when we were in Leicester to actually whether or not we did any specific messages for people who have hearing loss. So we actually worked with a few partners to actually develop this. It's available free on YouTube, and it's a signed, subtitled and also voiceover video. So actually it's obviously very useful for people who speak BSL. But also because of its voiceover nature, it's actually really useful for anyone to actually listen in, and it'll reiterate the main messages as well. And the good news for all of our program's work, they're all free. They're absolutely free to use. All you need to do is actually find the time to actually do it, really. That's certainly one of the principles of the whole ThinkCO program, is that it's open source, so our materials are free. So as well as learning a little bit about the programme, we were actually asked to give you, as I said, a sort of a few key messages about the dangers of carbon monoxide. before we sort of go through these next few slides, I thought I'd just reiterate, as I've been listening to you all this afternoon, it's been really interesting because mainly these messages in the past, when we've been doing the workshops in particular, they've been targeted at people who are actually out and about visiting people in their own home, as you do. Some of you are obviously still doing that, and certainly when there's an emergency situation with a client. But actually, I think some of these messages will be useful if you are not doing that, if you are actually assessing remotely. And I actually think some of these questions might be worth asking of your clients as well, even online or over the phone. So we'll start off with some of the dangers of carbon monoxide. So a few facts. Facts 1, carbon monoxide, that's an image of a carbon monoxide molecule. The formula of carbon monoxide is 1 part carbon and 1 part oxygen, and it's written down as CO. So both Simon and I will often just refer to it as CO in the course of the presentation. We say this and we start this really because people often muddle up carbon monoxide with carbon dioxide, CO2. That's a very different gas, but one certainly pre-COVID that actually had a great deal of publicity because of its connection to greenhouse gases and the carbon issues of the world. Fact 2 about CO. Here we go. Fact 2, hopefully, here we go. Carbon monoxide is a gas that weighs about the same as air. And what's key about it is it's usually generated when there is some combustion from a compliance, when there's hot air actually produced. So CO tends, like that hot air, to rise towards the ceiling. That becomes important when you actually talk about how you should fit a CO alarm, for example. And again, Simon will touch on that. And carbon monoxide is measured in parts per million, and we have a slide about that later. So fact 3, what's absolutely critical about carbon monoxide is that you can't see it, you can't taste it, you can't smell it, and you can't touch it. It means that our senses are absolutely completely unable to detect it when it's around us. It's poisonous, and it is also potentially lethal. So how's it formed? CO is formed when it's produced by carbon fuels such as gas, oil, coal and wood, and it's when they don't burn fully. What's also critical in that bullet point is that it's not just about mains gas here. We emphasise that it's about oil, coal and wood as well. Though most CO incidents are actually linked to gas, whether that be from a boiler, a gas cooker or a gas fire, but it isn't just about mains gas. What it's about and how it's formed is that the key of it is a malfunctioning appliance. Something is wrong with that boiler, something is wrong with that cooker, which means that there's actually insufficient oxygen enabling that appliance to burn correctly, to work efficiently, and carbon monoxide gas can form as a result of that. So what you're really looking out for are appliances that aren't working very well. And CO can be found in very low levels. It's actually a natural gas, so it's around us all the time, but in extremely low quantities, so we don't even know about it and it doesn't affect us. But when it is there in large quantities, and even sort of quite low ones as well, it can be dangerous, and it is found in dangerously high levels as well. Some more facts. So it's dangerous, it's odorless, it's tasteless, it's invisible, and potentially extremely toxic. It's lethal. Only about 30 to 50 people die accidentally in the UK from CO poisoning each year. That's the good news. And that figure has stayed stable for the last few years. But that's still 30 to 50 people who are affected by a CO death, and their families and their friends. We put purposely in that point about the fact that the word accidentally is in there, because carbon monoxide is used by people who actually take their own life as well, in particular within cars, etc. But these are the people who die accidentally in terms of the figure. It's also responsible directly for about 4,000 people going to accident and emergency each year somewhere in the UK, and also about 200 people from those 4,000 are admitted to hospital as a result. But critically, and very much part of this project, is the fact that there are suspected to be many more thousands of people who are affected by low-level exposure to CO, who simply don't know that they're actually being slowly poisoned by carbon monoxide because their gas cooker isn't working very well. We'll go on to discuss how you could potentially sort of work with them to see how that gas cooker, is it working well, is it functioning? But the suspicion is that there are many thousands of more people affected by it. The statistics are rare out there for that one, unfortunately, but there are some people working on it at the moment to sort of see if they can actually put some figures around that thousands. But we know, certainly from the work that we've been doing with ThinkCO, that that suspicion is probably very accurate. There are many more thousands affected. And we also do know that long-term exposure to low-level CO poisoning can lead to long-term brain damage, and it certainly does affect the nervous system and also the memory. So exposure to CO in the home. Inevitably, and thankfully, we're coming out of the months really where it's really important. CO incidents are higher during the winter months, as you can imagine, because the heating is on and the doors and windows are closed. Though there is some work going on at the moment about the fact that there is some suspicion that the fact that many people are obviously working from home, are being told to socially isolate, are being shielded, that actually there is the potential for increased CO risks because as a result of COVID-19 and the acts that we've been asked to actually do. If that continues through to the autumn and winter, that is an interesting challenge. So back to mains gas, which is the main way that most of us in the UK heat and eat within our homes and cook. So spotting some of the signs. Some of the signs, for example, on a cooker is a yellow-orange lazy flame instead of a strong blue one. One of the classic signs to look out for that that cooker isn't working very well. You've also got a gas boiler there. If the pilot light keeps going out on the boiler, or perhaps it's noisy, it simply means that that boiler isn't working very well. And therefore, there is the potential for CO to be formed if it's not functioning. In our workshops, for example, it's not unusual for Sam and I to hear stories of people who perhaps have been working with someone and supporting them, who have had the same boiler for 40 or 45 years. I'm sure you hear about these stories as well in the course of your work or volunteering. That's a real potential danger that CO is being formed. And also what to look for around the fire, the cooker or the boiler is sooty brown marks in particular, and that again shows that it's not actually working and functioning very well. Again, many of you will actually get this as well, but in terms of excessive condensation and the windows or walls of a property. CO doesn't form condensation and condensation doesn't form CO, but what it is a really good sign is that there's the risk that there is poor energy efficiency in that house. It's a fuel poor household potentially, and therefore there's the potential for whatever does heat that home not to be functioning very well, therefore the potential of CO. And what's actually critical is when you're visiting a client's home is to look out for blocked ventilation sources such as chimneys, flues or air vents, or actually when you're talking with someone over the phone, doing an assessment with them, asking these sort of questions about, for example, when was the last time their boiler was fixed or serviced, is a really critical question that Simon will pose with you a bit later. So some other sources of carbon monoxide around the home that aren't gas. The first one is calogas or LPG, that is carbon-based fuel, and if that gas fire isn't working very well, then there's the danger of CO being formed. Ditto if you're talking a wood-burning stove, increasingly popular, but also if that isn't working very well, the flue's been badly fitted, for example, there's the danger for CO poisoning there. And also coal fires. You're obviously burning carbon when you're burning coal. If the chimney is blocked, there is the potential for CO to be coming back into the room and poisoning whoever is sitting there. It's the same if you're working with clients who are not in a gas heated home, gas fueled home. It's exactly the same if you've actually got oil heating in the home and cooking, and also if you use an engine in some way, whether that be perhaps you're on a boat or you're actually in a car, etc. That can be another source of CO as well. And also if you smoke, you will naturally have higher levels of carbon monoxide in your body as a result of the smoking. But also if you're working in the home where someone is actually smoking, your client is smoking, there will be higher levels of CO in the home as well. So onto the symptoms, what to actually look out for. These are the classic 6 symptoms. The first one is headaches, the next one is nausea, the next one is dizziness, the next one is breathlessness, then the potential for collapse, and the potential for losing consciousness. Those top 3, the headaches, nausea and dizziness, are particularly low-level CO poisoning that you are likely potentially to come across in your work. The breathlessness, collapse and loss of consciousness are obviously emergency situations, and certainly in a workshop or actually in the e-learning, we talk about what to do in both of those situations, whether it's low-level or high-level. I mentioned at the beginning that we'll be talking about parts per million fleetingly. This is just a quick graphic that sort of brings home to you that actually 30 parts per million of CO in, around you in the atmosphere instead of oxygen, and you actually have 10% of your body is now carbon monoxide instead of oxygen. It then goes up, as you'll see. The top figure there is 5,000 parts per million. If you're breathing in 5,000 parts per million of carbon monoxide, you're dead in 20 minutes. It can go higher than that. We've certainly heard of incidents where it's 12,000 parts per million in an emergency situation, and in which case you would actually die in about 2 minutes if that was the case. So what to look out and listen for? Some of the symptoms, again, we're often talking about, we hear from people that they're often tired as a starting point, as well as starting to have that headache and feeling a bit nauseous. So if you're here and you're listening and you're talking with your client and they say that they're really tired, that's one common symptom to look out for. If you think about it, many of the symptoms that we're talking about are similar to flu and food poisoning, but they seem to go on for a long time. Most of us thankfully get over flu and food poisoning relatively quickly. But if it's going on a long-term basis, it's something to think about. Some of the symptoms are certainly similar to some COVID symptoms. And again, we're back to that work that I referred to at the very beginning, where people are thinking about actually, are some people actually suffering from carbon monoxide poisoning because they've been at home, and they might actually be misattributing it to to COVID. The dizziness that comes with CO poisoning can also lead to falls. So it's important, if you're involved in slips and trips programs, that sort of thing, that actually it may not be a change of medication that's causing the person to fall over. It might actually be low-level CO poisoning that's causing them to fall. And critically, especially if you think about things like being tired, that flu and food poisoning, when that person goes out of their home, the symptoms simply disappear because they're no longer in an atmosphere where there's CO poisoning present. So if you are talking and you're hearing from your client that they feel better when they actually go out to Tesco's, but feel a lot worse when they actually come back home, that's a classic sign that there may be something happen related to CO back in their home. And also to think about yourself. This is a duty of care situation for you when you're actually going into the homes of people. But also if you're hearing from your client that family members, grandchildren, for example, actually feel a lot worse when they're at home, but feel better when they go back to their own family home, that's another thing to listen out for. It's also worth thinking in the time of COVID as well, that actually the smaller you are, the more likely you are to actually get the symptoms of CO. So it's particularly important with children and babies, and also even pets in it, because the smaller you are, the higher that level of CO poisoning and the more parts per million they will actually be suffering from. Okay, I'm now going to hand over to Simon for the final bit of the presentation.
Thank you. Can everyone hear me? Nod from somebody.
Yep, we can all hear you.
Great, okay. Thanks, Hilary. Hilary's just given us a quick look at some of the features of CO, the sources, signs and symptoms. We now move on to some of the protection sides. Break it into two parts about servicing initially, and then a bit about CO detectors. So the key point around servicing is about getting your boiler and appliance serviced annually. It's a legal requirement to use a gas-safe registered engineer. What that means, to be on the register means that they are fully qualified and up to date with their training. It's also important to check their ID. They'll have a pass like that, and on the pass will describe what they're qualified to use it for. If there's a chimney or wood burners, or if there's oil, then HETEC and OFTEC are similar bodies to the gas safe register, but we have qualified, quality assured engineers that work with them, that qualification. We keep mentioning a bit about COVID. So there certainly are potential COVID-19 implications in what's going on around boiler servicing. For landlords, they have to legally do an annual safety check, and there are kind of issues around that going into households. And also potentially people are cancelling their annual boiler servicing as well, so increasing potential risks. This is something that the Gas Safe Register are particularly looking at, and they're updating their advice on a daily basis. I just checked and they updated it yesterday on their website. So it's worth keeping an eye on that if you're going into people's homes, linked to a sort of general advice about going in. So CO detectors. I'm sure most of us do have CO alarms. There are many different brands. The key thing is to ensure that it has a British Standard EN number, 50291 on it, and a British Standards kite mark. So detectors like that cost about £12 to £20 from DIY stores. Some of them are digital, like the one in the picture there. They show parts per million, and others are simply on and off. The alarm goes off or it's silent. Key message for them, because they do vary, is to read the instructions for the particular alarm you have, and like you would with a smoke alarm, test them regularly. The little pirate fellow there is a reminder to avoid pirate COs. And one of the reasons for that is the Consumers Association, which each year buy a series of alarms, often on eBay, and then test them properly. And a significant proportion, been up to 70–75%, have failed, and they look entirely like they're okay. So really, it's a recommendation you make. You know, if someone is selling cheap alarms, really avoid them and don't buy them on eBay or probably Amazon as well. So in terms of where to put your detector, the recommendation is that you would put one in every room where there is a potential source of carbon monoxide. That's not always realistic, we know, because that would potentially mean in the kitchen, in the lounge, in the boiler room, if you have one, that kind of thing. Part of this project is we recognise for most people, perhaps only one detector will be available. And so you need to really think through where would you be the best place to put that detector, and think about where the client perhaps spends most of their time. In terms of positioning, putting it high in the room on the wall, but 15 to 30 centimetres from the ceiling or from a light fitting. If you're putting it in the bedroom, and there can be boilers sometimes as part of bedrooms, place it about bed or breathing level. Put it 1 to 3 meters away from a cooking or heating appliance. So don't put it directly next to it, at least 1 meter away. Avoid drafts, avoid damp like bathrooms or enclosed areas like under the stairs. You can get alarms which are for bathrooms. They're just not as easy to find. Key thing really is to make sure it's audible. So wherever you are putting that alarm, make sure the person can hear it if it goes off. Think about your clients that have got sensory deprivation. People with hearing loss, you can get alarms which are vibrating pads to put under the mattress, and also consider people with learning difficulties. So if carbon monoxide is suspected, what you should have is a plan of action for what you would do in that situation. When we do the workshops, this is actually a significant, arguably even a third to 40% of the workshop. But we're just going to go through this, covering the highlight points of what we would do in terms of thinking that through. So it really should be a part of your organization's health and safety policy. Think about who you report to, and that's really important, just to if there is some sort of suspicion of an incident, that you actually follow it through until it's completely resolved. Think about your short, medium and long-term aspects of whatever occurs. Also, how can you get support, either financial or other, to help the client? Might be getting a replacement boiler or help with getting a detector. Know what to do in an emergency as well as low-level situations. So it's about training the staff and your volunteers. So in terms of the top tips, we have linked to that training. Make all your staff and volunteers CO aware, so new and established. Include it in the induction. Listening to your clients. I think as Hilary alluded to, but even if you're not meeting people or visiting people's homes, listen to what they're describing and think about the sources, signs and symptoms of CO and see if there are any connections. Always investigate further if you've got any concerns. Encourage your clients to get their gas appliances checked annually and always use a gas safe registered engineer. Also use HETAS or Offtech as well. Advise your clients to fit an audible CO alarm and make sure it's of the right quality standard. If you want more, the e-learning course with more detail, including more case studies and examples. We have the pilot webinars and online workshops, free materials that are available from us, but also from the Gas Safe Register. So if you're interested in the e-learning, All you need to do is just email us that to that address, e-learning@gassafecharity.org.uk, and we will arrange for a registration and let you know when that's all set up. If you've got any other inquiries about the programme, then just email us at thinkco@gassafecharity.org.uk. Okay, that's the very brief overview. If there are any questions, I'm sure they've been flitting away. Hillary's back as well.
Yeah, I think you've been answering some in the chat box, haven't you, Hillary?
Yeah, I've been having a go.
Yes. Becky just asked about using the Philp Gas Safe funding to buy CO alarms. That's one of the things you can't use the funding for, unfortunately. But we do from time to time have some to give away from other sources. So keep an eye on the Foundation's newsletters for those. And if any of you don't use the CO funding we have available, then please get in touch. We spent most of it for this year, but there'll be another round later in 2020. So thank you, Simon and Hillary. So we're slightly late coming to you, but thank you for
no problem.
This afternoon.
No problem. Thanks ever so much, Paul.
So yeah, thank you. Thank you.
The DFG Surgery. Your questions answered.
So we're running a little bit late, but has anybody got any DFG questions they desperately want to pitch in? There are a couple from earlier around the app that I showed. In terms of security, I think it only stores the photos and the notes on your actual phone, and you can convert that into a PDF, which you can email or upload to your own systems. I don't think it's stored anywhere else. And yes, it doesn't go anywhere else. So it's as secure as your phone, I guess. And it's £5 per phone that it's uploaded from. So your contractors will need to buy that as well if they need to. Some questions about pooled resources and DFG funding. There's certainly discretion to have pooled funding around smaller adaptations, and I think kind of it's a live debate around whether DFG should be the lowest cost possible, or whether you should aspire to do something a bit more than that and look at, I suppose, the value for money in adapting a home within your area that's going to be available as an adapted home in the longer term. So there's certainly discretion there to have that debate if you would want to. Has anybody got any DFG related questions that they'd like to ask? The name of the DFG app, I can't remember off the top of my head, but you'll be able to watch the video back afterwards and see all the links. So just in case anybody else has got any last questions and you're typing them away. And just to remind you, we do free training on the DFG basics. We do 2 of those a week, and they're full for the next 2 or 3 weeks, but we'll be adding some more dates. They're always very popular.
Find out more at foundations.uk.com.
And if you also want to speak to us about the DFG quality standard or workshops or anything else, then please get in touch.
Poll time. Let's see what you think.
That's not a poll, but our next webinar will actually be on means testing in social care. So one of the things that, if you remember from the DFG review, it recommended looking at the Care Act means test or Care Act financial assessment as a way of doing means testing for DFGs. So we've got a webinar on the 2nd of June, which explains how that works and how it might also apply to DFGs as well. Quick question from Louisa in the chat box. Disabled child. Child has been placed with a foster home in another borough. The child needs adaptations. Who's responsible to fund the works? If it's a long-term foster placement and it's going to be 5 years or more, then the foster parents can apply for a DFG up to £30,000 to the borough where they live. Anything over £30,000 is discretionary, so that's usually paid by the social service department where the child comes from. Any last questions for today? One last one from Penny then. Do we know any DFGs have been awarded for adults with autism to fund quiet rooms within the home? Yes, There have been, I don't know how many in total, but Dave from Foundations is currently working on a guide for autism in the home. That will be available fairly soon. So thank you all for joining us today. We've had a record number of people on the webinar, which seems to happen every month at the moment. And if you're interested in continuing the conversation, then we also have a private Facebook group at facebook.com/group/DFG Champions. And we're just approaching 1,000 members. So if I can catch you the 1,000th member, I'm sure we'll sort some sort out a prize for our 1,000th DFG champion. So that's all for today. We'll have the video up on the website later in the week. It also goes on YouTube. And so we'll be back on the 2nd of June with a webinar on Care Act financial assessments. And we'll be back with a Foundations webinar later in June. I'm sure we'll return to the topic of remote assessments. I did see a number of people mention Attend Anywhere as a package that they were using. So if anybody's actively using Attend Anywhere and would like to do a demo next month, then please get in touch. Otherwise, hope you're well, hope you're safe, hope the people who are in bed have stayed awake, and we'll see you again next month.